Okay guys, so here I am just going to give you basic information about the flaps and a few more things, and then I'll make an audio to cover everything in the detail. Okay, so first thing is that we have couple of things like flaps and gingivectomy, and we don't know where to decide, how to decide whether we are going to do what procedure. So for ADC, remember, if you are going to talk about the gingivectomy, so gingivectomy, it's better if you have the gingival pockets, right? So if you have gingival overgrowth cause of any reason, so you can safely go for the gingivectomy, and you will cut that part, and you will reduce the false pocket that is formed over there. Now what is a false pocket? False pocket is, suppose this is your tooth, actually you all know it, but again I am explaining it. Suppose this is a tooth and then you have your gingiva over here. So if the gingival growth occurs, that means your pocket depth will increase. Okay, so this is the false pocket that is being formed just because your gingiva is going in the coronal direction because of any reason, because of plaque or drug. Now the another question that they usually ask is what is the most common cause of this? Is it the plaque induced or is it the drug induced? So answer it is the plaque induced. Okay, now the second thing is that suppose there is, usually if there is furcation involvement, so usually you will go for the flap surgery. So F for furcation, F for the flap surgery. So one way to remember is like this, just for the easy distribution and easy classification. Now another thing, when you are talking about the flaps, now we have two types of the flap. Flap is that you have this tooth and you have your gingiva over here. Let's say till this area you have the gingiva. So one thing is, you will take this gingiva, you will raise the flap, means you will take the tissue from here, you will raise the flap, you will reflect this flap, and then you will do whatever you want to do. For example, you want to do bone contouring, or you want to reduce bone, or you just want to go for the subgingival instrumentation, whatever, right? And then after you are done with it, you will again replace the flap over here. So that means one is the replaced flaps. And the other thing that we have is the apically replaced. Apically replaced flaps. Now when apically replaced means you raise the flap from here and then you took it apically and you sutured it somewhere here. Okay, so you repositioned the flap. One is the flap where you replaced it back, and the other is when you repositioned it to a different location. Now when you are talking about the replaced flap, that is when you put it back to its position, how can you use this flap? Why do you need to raise the flap? As I said, you can raise the flap for bone removal, or if you don't want to remove any bone, for the instrumentation, or you want to assess the root surface here. Then also, suppose you have a deep pocket, you want to assess it, so for that access you also can raise the flap and then you reposition it. And because you repositioned it at the same place, that is you replaced it, so this is aesthetic, and it is aesthetic plus there is a rare chance of the dentin hypersensitivity, basically no dentin hypersensitivity. Now in the other one that we have is the apically replaced, and again there you can remove the bone or you can not remove the bone. It depends upon what procedure you are doing. Now what you do there is, suppose you have this tooth. Okay, this is a bad tooth. So suppose you have a tooth here and this is the root, let's say, and then this is the bone. So this is my bone, this is again bone. So suppose this is bone and this is the tooth. Now earlier, suppose my gingival attachment was like this. Okay, so it was here. So what I will do is I will raise the flap, and whatever I want to do, if I want to reduce the bone, if I don't want to reduce the bone, I simply want to instrument over here, whatever I want to do. After doing whatever I wanted, I will simply lift the flap, take it back, and I will suture it here. Right? So earlier my tissue level was this, attachment was from here, but now this level is here. Now what happened? Earlier my crown length was different, right? So my crown length was different. Now my crown length has become more. So I have also done the crown lengthening. One thing is this, I have done the crown lengthening. Second is I can now assess the root part. I can do the instrumentation. The third thing is I can eliminate the deeper pockets. Okay. So with this apically displaced flap, this will lead to the access to the deeper pockets. But with this, the dentine hypersensitivity can occur because of we might expose the area. So dentine hypersensitivity can occur, and it is not aesthetic because we are taking it back. So we are positioning it apically like here. So that is not for the anterior teeth. So this is not very aesthetic. Right, now suppose I raise this flap and I wanted to do something with this bone. So what I can do is I can even do certain things with the connective tissue and with the bone as well. What I can do with the bone is I can do the osteoplasty. Osteoplasty is bone is not removed but bone is recontoured. Or I can do ostectomy. Ectomy is when you cut something. So ostectomy is when I remove some parts of the bone. Okay, so this was about the flaps. Now sometimes we have to do the mucogingival surgery. Now before mucogingival surgery or any kind of actually surgery, after we do this surgery and we have instrumented the root surface, what happens is, you all know that our tissue is always made up of, outer layer is the epithelium and underlying is this is the connective tissue, right? So this is my epithelium, right? So suppose there is a tooth, this is the root. So suppose this is the root and I have this gingiva over here, the growing. That means first layer will be the epithelium and underlying will be the connective tissue. Now always my purpose of the periodontal therapy is I want the connective tissue attachments, right? So the purpose of the surgery is I want the connective tissue attachments, but the rate of these two tissue proliferations is different. Usually the epithelial tissue, it is fast to grow. So what will happen? The epithelial tissue will keep on growing at a faster rate. Connective tissue will not be able to join. So this one will be it will form the long junctional epithelium. So we want to avoid the long junctional epithelium. Now how can we avoid the long junctional epithelium? If we put a barrier membrane between the tooth and the this epithelial. So if I put a membrane over here, what will happen? The epithelium will not be able to grow, but the connective tissue will slowly keep on filling the defect, right? So gingival epithelium and connective tissue will be growing at a proper rate. Why? Because the epithelial will not be allowed to grow at a faster rate to cover all the space, and the connective tissue will get a chance, right? So this membrane is provided, and this is called as the guided tissue regeneration. So the